Okay. All right. Well, hi, everybody, and welcome to the fourth installment of the OSP Healthcare Leadership Insights webinar. I am your host, Stacy Hurt. I am a senior health advisor at OSP and a HIMSS digital changemaker. I am so excited about today's episode, and I want to thank you for joining us. There's a lot of competing events right now, a lot of webinars. So my guest and I certainly appreciate you taking time to join us today. We are going to talk for about 45 minutes. And at the end, we're going to have about 15 minutes for Q&A, of which you can interact with us. So I am very pleased to welcome my guest, Mr. Abner Mason. Abner is a healthcare technology leader and founder and CEO of ConsejoSan. He strives to create a more just, equitable, and effective healthcare system and reduce health disparities. I can tell you, I was looking at Abner's LinkedIn profile, and as I said to Abner, what strikes me about the work that he's done his whole life is it's been a bipartisan effort to make change in health equity. And to me, somebody who's a unifier, that's a really important effort. And Abner's going to talk more about all of that, but I'm just going to quote him: when you want to do big things, you have to do big efforts. And I appreciate that. Speaking of which, we can all learn more about bridging the gap in health inequity and providing equal health care to all people and communities, irrespective of disparities. Abner has years of experience in addressing healthcare disparities that still pose a challenge, even in today's technologically advanced world. The main agenda of today's episode is to understand how health disparities can be reduced with virtual care practices. So I'm very pleased to welcome Abner Mason to today's episode. Abner, how are you?
I'm doing great. Thanks so much for having me here to have what I know is going to be a really exciting discussion. So glad to be here.
Yeah, well, I'm just happy that I got to you before Health 2021 because you were the standout at Health 2021. And just real quick, I wasn't able to attend, but I followed all of your good work there. And I just wanted to ask you, how was Health and what stood out to you as some of the emerging themes or things that you talked about?
Sure. So Health it was in Boston. It was, I think, really exciting to see people back. I think it was the first conference that I got the sense that people were back in big numbers and excited to be there. As I looked around at the folks who attended, there was this is going to sound kind of crazy, but I think it's true. There was almost a kind of joyous feeling. People were seeing each other for the first time in a long time. Lots of hugs, lots of catching up. So I think that was really exciting. And people having that sense that we can get back together in a really big way and make change. So I think that was really positive. And then the other thing I thought that really stood out was the discussions, how much of the discussions included health equity. We have really changed since pre-pandemic. If we went to healthcare conferences before the pandemic, and it's not just the pandemic, I think it's the combination of the pandemic, the disparate impact of COVID on communities of color and low-income people, combined with, and I really think it's important that I think it's the combination combined with this really intense discussion that happened in 2020 around health equity and racial justice. It started with the murder of George Floyd, but there was a kind of national discussion, and it actually became global too, as you know, but certainly in the US, there was the kind of discussion that I had not seen in my lifetime. And so I think people are in healthcare specifically, I think it's also true generally, there is an unusual willingness now to say the status quo is not sufficient, that we have got to make change, that the way things have been working in healthcare is not the way they should continue to work. And you know, you and me and some of us have been talking about health equity for a long time, but the truth is, you know, I don't know if you'd say we were a voice crying in the wilderness, but we were certainly, what we were talking about was not at the center of discussions and the center of people's thinking. And there has just been a tremendous change since, you know, since 2020. And so I think that when I look at this health compared to the health I went to in 2019, completely different. Health equity was part of almost every discussion. And I think it's a wonderful thing. It's a good thing. We've got to make sure, I think the challenge though is how do we take advantage of this moment? How do we make sure that this unusual set of circumstances that brought us to this moment, and the circumstances are crazy unusual, a once in 100-year pandemic plus a kind of forced discussion around what kind of country we want to be, you know, in America. Those two things happening at the same time, it's almost miraculous that they happened at the same time, but they did. And now we have this moment, and that I think, you know, people are of goodwill for the most part are saying the status quo is not enough. It's not good enough. We got to do better. So I think it was just tremendous to see the difference at health and how health equity is at the center of almost every healthcare discussion.
You know, that is so encouraging to hear. And you know, and everybody who knows me, if you follow me on Twitter, you know, I'm very outspoken and I just tell it straight, you know, and I'm sitting here talking to you as, you know, a white privileged American, you know, who has access to healthcare, any healthcare I want. And as part of my career, you know, I worked for a nonprofit in colorectal cancer, and we did a lot of work in the FQHCs, you know, and getting them screening for colorectal cancer, getting them fit kits and whatnot to screen people in those communities. And so I was going to the underserved community, and you know, I was talking to people about the challenges, you know, transportation, what a challenge it was just to get to the doctor. And it was only through that work, Abner, that I got a true understanding of what was going on. And I understood it. And then I just assumed everybody understood it. And that was so not the case until, like you said, really these past 18 months, that it was really brought out the gaps in, I'm just going to say, because I can, the haves and the have-nots. Right. And the gaps between getting that health care and not having access. And like I said, I didn't realize that people didn't know how bad it was. You know, when I saw it, I just thought everybody knew it, and they didn't. And I'm just so encouraged, like you said, that this has come into the mainstream of conversation, and that we're digging into this, and we're going to finally do something about it. It's terrible. It took a global pandemic, and unfortunately the loss of life, you know, the loss of so many lives to do that, but we're doing it. And so, you know,
it's a hopeful moment. You know, I think it's, and that's the good news. But again, you know, we've got to make sure that we don't squander the moment, because we can, if we don't take advantage of this time to really put into place policies and make decisions about how we want healthcare to work going forward that are sustainable, we could look back at this time and say, you know, foolish us. We had an opportunity to really improve our healthcare system, and we didn't take that opportunity. We didn't, you know, take advantage of the moment. And so I think this discussion is really important. And a key thing here is it begins with discussion, but we've got to make sure that we don't just confuse discussion with action. And so I think we're at that moment now where we need to be thoughtful, and but we need to be decisive and take action. We've got to do things. Talking about them is an important first step. I don't want to minimize the importance of the discussion, because if we don't get people talking about it, we won't get the brightest and minds and around the table to fashion solutions. But that can't be the end. This got to be the beginning of what we need to do, which is really taking meaningful steps that will produce, you know, a healthcare system that works for everyone.
Right, right. So with that, that's such a great entree into our discussion because you are walking the walk. So let's get into it. Just all of your extensive experience in working to resolve health equity issues. Can you briefly tell our audience what inspired you to establish ConsejoSpano?
Sure. I had been doing a lot of work with on the issue of HIV/AIDS. So it was another pandemic, where we needed to figure out how to do better because the healthcare system wasn't doing a good job of addressing the HIV/AIDS pandemic and the people who were affected by it. And so I started a nonprofit called AIDS Responsibility Project. When I left, I'd been working in state government in Massachusetts. I was chief policy advisor for a couple of governors. And so I decided I wanted to do more of this work. I was appointed to the Presidential Advisory Council on HIV and AIDS by George W. Bush. And I got some great stories to tell about that whole experience. But I ended up starting a nonprofit and we focused on reducing stigma and discrimination in the workplace. And so I created the nonprofit I created. We created the first business council on HIV and AIDS in Mexico. That worked with employers to agree, we got large employers in Mexico to agree to take specific steps to reduce stigma and discrimination in the workplace. It was an incredible effort. I think we really transformed the way that the HIV/AIDS was dealt with in the workplace, which was a big step toward helping to make sure that we could have prevention programs that were effective. But in the process of doing that work in Mexico, I realized that it's interesting. I saw that the mobile phone was being used in Mexico in a way, delivering virtual care. And this was in the 2003, 2004, 2005 era. That was extraordinary. I met a telemedicine company, got to know them in Mexico at the time. They had more folks in Mexico using their telemedicine, telehealth solution than all of the US companies combined. This was in 2004. And so it was interesting to see how innovation they were using, and it was mostly telehealth, not much video because they didn't have a lot of broadband, but it was telehealth, and it was really successful in Mexico to bringing a really high quality, confidential, cost-effective healthcare to the growing middle class in Mexico. And I had this idea when I saw that. I thought, if we could do something similar in the U.S., we could help address the disparities that existed with Latinos in the U.S. And so the initial idea behind ConsejoSan was really a telehealth solution. I partnered with that company in Mexico. And initially, when we launched in the U.S., we were connecting Latinos in the U.S. with native Spanish-speaking doctors in Mexico. This was in 2004. Now, that solution, which I still think is a great idea, like a lot of entrepreneurs, my idea, it was fantastic. We got some initial employers to use it, but it was an idea whose time had not come, because I wanted to really expand that solution to the vast majority of Latinos, and I wanted to work in the government program, in particular Medicaid, to serve low-income people in the U.S. And we just couldn't find a way to use an offshore solution to serve a Medicaid population. And so I had a pivot. And that's when I had the idea. Actually, it was one of my customers who had the idea that we should engage his patients. In this case, it was the FQHC. He said, Abner, I can't use the doctors in Mexico. Great solution, but I can't use it because I'm doing Medicaid. But if you can help get my patients into my clinic, if you can help me engage my patients, build a trusted relationship, navigate them into my clinic, not to talk to a doctor in Mexico, but to talk to my clinics, we can do business. And that's became how the new model for ConsejoSpano. But it's interesting now that telehealth and virtual care has become so popular that solution, maybe if I had it, if I had introduced it now, maybe it would have had more success. But we've been very successful as we pivoted to becoming an engagement company, building a relationship with patients and members in the U.S., navigating them into the healthcare system.
Yeah, wow, what a story. Well, I shared the story about my son's diagnosis, and he was diagnosed back in 2006, and it was a lot of the same things that he's non-ambulatory, he's nonverbal, and I had to lift him and transport him to all these appointments. And repeatedly in 2006, I was saying, can we do this via computer? Like, it's 2006, we have all this technology, and, you can't tell me that I can't connect with a doctor, through the computer. And I was repeatedly told no. So, you were definitely ahead of your time in that solution. And it's unfortunate that society wasn't ready for it. But obviously, we are ready for it now, and you're doing it. And, so it's amazing. And we'll keep talking about all of that. But so fast forward, let's talk about, another point in time, 2010. Let's compare virtual health back in 2010 to now. What is the difference? And have we made any progress that's really addressed the challenge of reaching patients?
I think, no question, the answer is yes. I think in two ways. In 2010, there's actually a New York Times article one of my colleagues gave me that asked the question, is America ready for virtual care? And the answer in 2010 in that New York Times article was no. That doctors really no, they weren't. They didn't want to be. I think that it's interesting that I'm glad we talked about Mexico, because there really was this difference. In the US, we had a long sort of history of how medicine was regulated and what people were expecting. In-person care was definitely expected. State practice of medicine regulations. Doctors are licensed by the state, not the federal government. And so it really made it difficult for a host of reasons for virtual care to really take off in the US, because the doctor had to be licensed in the state where the patient was, not where the doctor was. I love doctors, but the truth is that they behaved in this way, sort of like a guild. They were protecting their incomes. And so a lot of doctors in certain states were the same way taxi drivers felt about Uber, and hotels felt about, Airbnb. They were like, there's this new technology coming in.
Encroaching,
and it's
right.
Encroaching on my turf.
Right.
And my income is largely dependent on my patients coming in to see me. If my patients can see anybody and pay less for it, it's going to threaten my income. And so, there's a big battle that happened between Teladoc and the Texas Board of Medicine. That was a huge fight. And to Teladoc's credit, they sort of took the point and the lead. But ultimately, I think we have come to see that we've got to get policy a little out of the way. These old regulations that prevented telemedicine and virtual care from expanding had to change. And so that's one of the big changes that happened. And then when the pandemic came, of course, they waived, the regulators waived these sort of state practice of medicine regulations. And it really allowed us to have this really blossoming and robust use of virtual care. We'll see what happens as the pandemic gets behind us. And we can talk more about how regulation has played a role there. But that was one factor comparing 2010 till now. We had to go through this process of kind of fighting through and sort of saying what's best for patients probably is the priority, and not necessarily what is best for doctors in a given state. The doctors are going to have to give a little and be willing to embrace new technology. And the other side of it is that a lot of these, and this part we still haven't fixed yet, but a lot of these solutions, telemedicine solutions in the US, were built for higher income patients. They weren't built for lower income patients. And so the way they were built and is fairly high cost. And there was just an unwillingness by regulators to pay for it, for instance, from the Medicaid program. So even up until the pandemic, with FQHCs in many parts of the country, California being one where we're based, federally qualified health centers, which are the places where low-income people go to get their care. They're part of the safety net. In California, like a lot of states, they could not be reimbursed for a virtual visit. The patient had to literally come into the clinic, cross the threshold in order to get reimbursed. And so most of the FQHCs were not doing virtual care because you can't provide care you can't get reimbursed for. So they had never done it. Their patients had never done it. So because of these regulatory constraints, because you couldn't get reimbursed, along comes the pandemic, and the regulators said, well, okay, I guess we're going to have to let folks at these low-income people use virtual care. And there was a huge uptake. So I think that's another change that has happened. Now, again, we have to see what the regulators do post-pandemic. But the first point I'd make is it's a shame that it took a 100-year pandemic to allow low-income people to use innovative healthcare solutions that higher income people had available to them the whole time and often didn't want to use. There wasn't even that much uptake, but in any event, it took a pandemic to get regulators to sort of widen the lens and say, maybe these low income people should be able to use these solutions. So hopefully going forward, we won't, sort of slip back into the old way of doing policy that says that innovation in healthcare, we're going to kind of limit it to higher income people and not let lower income people benefit from what are some amazing solutions that are coming, down the road.
Well, I mean, gosh, there's so much I want to say for what you just said. And you and I, we are, e-friends across social media, and we always talk about these same passions that we share for telehealth and how much telehealth has helped people, care from anywhere and getting the services to where the patients are, and, you used a couple examples. I use the examples of the patients that I advocate for that are, I have a patient in rural Mississippi, nowhere near an NCI, a National Cancer Institute accredited center that has, clinical trials and the latest treatments and the latest technology. And, she doesn't have access to transportation. Again, she's in the midst of financial toxicity from cancer, and how can she get a second opinion from an NCI cancer center that the closest one, may be Emory, over in Georgia? I don't know, but that's where telehealth can really help. It connect, in my world, can connect cancer patients in underserved, very rural areas to, getting the care that they deserve, the same care that I'm getting, even though UPMC Hillman is 20 minutes down the road. I mean, that's where technology can help. And going over state lines and what us needing a national license post-pandemic, that's a whole nother conversation. Let me bring it back. Anyhow. Yeah, I mean, it seems so clear to Abner and me, and let's hope it's having that same clarity. Anyhow, okay, so back to the pandemic, and we're talking about this, but specifically, Abner, how did the pandemic impact health access in multicultural and rural communities? What hardships in particular did they face?
So, the challenge for low-income people in general, and that includes a lot of multicultural people, but I think it even goes beyond multicultural. Low-income white English speakers also struggled when clinics were in effect closed in that first phase of the pandemic. When you couldn't get into the clinic, we had to shift to virtual care. And a lot of the providers, for instance, FQHCs, these safety net providers that we work with at ConsejoSan, they had never done virtual care for the reasons I just talked about. They couldn't get reimbursed for it. And all of a sudden, overnight, they had to stand up a virtual care solution because it was the only way for them to see their patients. So I think one of the struggles was, if we weren't doing it before, how do we do it quickly? On the clinic side, the doctors had to figure out how to do it, but also patients had to be able to use a solution that they had never used before. And there was this question about whether they would be able to use it. And what we found was that there was an eager willingness to use it on the part of low-income people. I'm talking about a lot of Medicaid patients. We ConsejoSan generated tens and tens and tens of thousands of appointments that were telehealth appointments. And so what we found, a couple of things. One, these are populations that if you reach out to them in a way that is culturally and linguistically appropriate and introduce the new solution, they will use it. That's one important thing. The second important point is you've got to be a little more patient-centric, though, because what we found is that patients that we reached out to for appointments, they overwhelmingly, by 10 to 1, preferred phone to video. Now, so we have this situation. Yeah, they preferred the phone, telephonic to video. And so we now have this big discussion going on about going forward, how do we reimburse? Because already some regulators are saying, well, we should reimburse higher for video than telephone, because in their minds, they think that a video visit is more meaningful than a phone visit. And I'm not going to argue that point. What I'm going to argue is that we ought to prioritize what patients want and what patients want to use.
How is that fair? Like, how is that fair? I mean, maybe somebody is blind or visually impaired, okay, and they can only access telephonically. So you're basically working against that patient, you know, for something that they didn't ask for.
Yeah, and broadband is a real issue. You know, we think that broadband is everywhere, and it isn't. There are huge parts of the country, and it's not just rural. There are even the urban areas where you have problems with broadband. And also, even if there is access, we have to remember that when it comes to broadband, there's two issues. There's availability of broadband, and then there's access to the internet. Low-income people, many of them can't afford an internet plan. I know what I'm paying, you know, what these internet companies charge. You know, I'm not going to argue their pricing is off, but it's expensive, and a lot of people cannot afford it. So we've got frequently there's two barriers. There's, do I have broadband for video? And even if it is in my area, can I afford, you know, an internet plan that allows me to utilize it? So for a whole host of reasons, people prefer phone. So my point is, going forward, from a policy perspective, we have to start to see policies through a health equity lens. And when you look at this issue of how do we reimburse for virtual visits going forward, we now know that we don't want to do what we used to do, which is to not even let low-income people have virtual visits. We know that was not the right thing to do, so let's not go back there. So let's agree. But going forward, if we're going to allow virtual visits, are we going to prioritize how people want to engage, meet them where they are? And overwhelmingly, they're going to choose phone, at least for a while. Now, that may change over time, and that's fine. But I think healthcare has to be more patient-centric, what I call, I would say, focused on treat the healthcare, the patient like a healthcare consumer. And when you have a consumer, you don't say to the consumer, I don't care what you want. Here's the pair of shoes, they're red. You take these red pair of shoes. If the person says, I want a black pair of shoes, no, you're going to wear a red pair of shoes. We have to say, as a healthcare system, we need to try to meet people where they are and be more consumer focused. And if people are more comfortable using the phone, we should let them, and we should not reimburse differently. Because if you allow reimbursement, if you say that video is going to be reimbursed at $2 as an example, and audio at $1, you and I both know the whole healthcare system is going to shift and only offer video, because they're going to say, well, we can make more money on video. And so it's going to shift to video, which means that what people want, what they're willing to use is not, and so you're going to see usage go down. So it's a simple idea here. Listen to patients, and to the extent we can, always sort of lean in the direction of what people prefer, because you will get much more engagement and use if you do that, rather than forcing people to take what they don't prefer.
Is everybody hearing this? Can I broadcast this across America? I mean, this is everything that needs to be said. Like you said, if you're forcing people into a virtual visit, you're alienating large groups of people that, again, did not necessarily, for whatever circumstance, are not able to use a visual component. And they're only, whether they're an elderly, or maybe, you know, we're ending Health Literacy Month. It's knowing how to use that technology, fear of that technology, adopt it, whatever it is, access, cost, choice. I mean, why would you do that? Why would you purposely alienate an entire group of people? That, and the other thing that you said that really resonated with me is, Abner, basically what we're talking about is a reimbursement of time. No matter how that time is spent, whether it's visually or telephonically, it's valuing that clinician's time in treating that patient. And like you said, the patient choosing how they're consuming, you know, that healthcare. And
I'm not arguing, just to be clear, that against the view that a video visit is better than an audio visit, because I actually think the video visit is more robust. You can see the home, you can look, there are things you can see. But here's the thing: if people won't use it, then I don't care how good it is, it can be a gold-plated solution. But if people won't use it, then we're nowhere. And so it makes more sense to prioritize what people want. And maybe over time you build relationships with them, and they can as broadband becomes more available, hopefully we can get this infrastructure bill that's in the Congress now. We have this crazy situation where both House and Senate have passed this huge infrastructure bill that includes a lot of broadband work to improve broadband, and the president supports it, but we can't seem to get it signed because we have this, but fingers crossed that we can get this piece of legislation signed, and that the carriers, do their jobs and take this money and actually, deliver on it. Because, in the past, they have not done the best job of taking funding available to them to really build out broadband. I don't want to be overly critical, but let's make sure that this time, if we can get this legislation through, that we actually build out broadband. So I think that video is a big part of virtual care going forward. I just want to make sure that we should at every turn be in prioritizing what patients are comfortable with, what they want, what they'll use, because having a patient use something that may not be gold, it may be the silver solution, is better than nobody using the gold solution. So, we just got to prioritize what people want and will use.
Yeah. No, 100%. You touched a little bit on this, and our chat is just lighting up. It's so robust. I'm seeing it, and we're going to address it at the end. Thank you so much for participating, our audience. And you touched a little bit on this in terms of a policy standpoint. A lot of people are buzzing in here, and they want, really the step-by-step. So what can health leaders do to ensure health equity with digital healthcare?
So that's a really good question. And let me start it by saying, I think that this is my view. I think that going forward, virtual care is going to be a significant part of healthcare in America. And when I say virtual care, it's not just the traditional visit that we think of today. Already, there are solutions out there that are adding remote patient monitoring devices to the home. They're not in the not too distant future. You'll be able to have almost as robust a visit with a doctor while you're at home and the doctor's at his or her home or office as you would by going in, because we're going to have all of these devices in the home. And so the brick and mortar healthcare as we know it today, I'm not saying it's like Sears and is in its future, or Blockbuster,
Right.
but I think that we are, if you look 20 years down the road, a lot of the brick and mortar that we see today is going to be gone. A lot of it. And I think a lot of the brick and mortar that goes away is going to be in rural places where it's very expensive, or in inner cities where it's very expensive. And so concierge type solutions might stay, but for low income people, the clinics they're used to and the brick and mortar they're used to is not going to be available to them. We're moving toward more virtual care. And if you see it that way, you see the urgency of us making sure that future that's not too far down the road, where virtual care is so much a part of healthcare, that we have built that in a way that doesn't reinforce existing health inequities. So we need to really be thoughtful now, because now is our chance to make sure that future, which is not that far away, where people are going to be getting a significant amount of their care through virtual solutions, that it does not, we don't make the mistakes we've done in the past and not done it with a health equity lens. So for instance, we need to, if you see it that way, it's not just providers who need to be involved here. In fact, I think too much pressure is on the provider. A provider cannot fix the problems that we have today, and certainly cannot help make sure that we shape the future in a way that's more equitable. They're part of the solution, but they are not I don't even think they're the majority of the solution. I think what we need is policy change. It's policy that will drive the kinds of changes that will create that future that's more equitable. It's not what a single doctor does in his or her practice. Now, what they do is important, but we need bigger, we're at a point where, we need bigger policy change. So for instance, we need to do things like say, we're not going to reimburse unless our reimbursement policy is going to be seen through a health equity lens. For example, we're going to encourage innovation that is done as well with the health equity lens, and we can talk about some of the ways we can do that. But I don't want to put the pressure on, on the shoulders of providers to say, you need to fix the system when they're kind of living under the existing rules, and they alone can't do it.
Yeah, no, I totally agree. I mean, it's that whole field of dreams. If you build it, they will come. I mean, the providers are just delivering the services, but they have to, like you said, it's about infrastructure, it's about policy, drive it, I mean, you got to follow the money, and the money, what the money is going to pay for is what the providers are going to deliver on. And and just back to an earlier point that you had, as a consumer of telehealth, et cetera, and a patient stakeholder in the ecosystem and a caregiver, all we're asking for is choice. All we're asking for is choice and options, because you can't, we see, like you said, when we force people into a situation, they're going to rebel. They're not going to be comfortable. They're not going to follow a plan because they're not able to, or whatever. And all we're asking for is for that option to remain, post pandemic. And for a variety of situations, it's just, and the sort of this emergence of patients sort of speaking up and saying what we need. And now with consumer demand and patients being consumer, like I say on all my panels, patients have a voice and patients will have a choice. And that's, and that's the way it's going to fall down. So back to our provider friends. So how can healthcare providers utilize virtual healthcare to understand patients on a cultural level? I know you've been writing a lot about this and speaking a lot. So what can they do?
So I think that, again, providers are part of the solution. I think what we need to, I just throw out a couple of policy suggestions that I think will have the effect of changing the whole environment, especially for providers. So one, we need to collect race, ethnicity, and language data. If the provider knew more about who their patients were, they would be in a better position to serve them. But we can't rely on just the provider alone to do that. So it's 2021 and we're still not collecting race, ethnicity, and language data. So think about this. We know our healthcare system has enormous disparities that many of them are based on race. Many of them are based on income. We today in America don't collect race, ethnicity, and language data. So we don't have a way of really having a baseline so that we can really get a handle on where the disparities are and then target programs or initiatives to address those disparities. So policy suggestion number one, we need to collect race, ethnicity, and language data at every level of the healthcare system. That means from the state, if it's a Medicaid program, when they're collecting Medicaid information, the plans, whether it's Medicaid, Medicare, or commercial or exchange, they need to collect race, ethnicity, and language data. Providers need to collect that data. And then so that people don't have to say it again and again and again, we need to have a robust health information exchange in every state. And they should be able to communicate with each other. That's connected to the whole interoperability thing. So what I'm really talking about is we should be able to share data more freely. We should collect it and we should be able to share it more freely. These are policy things, though. One provider can't make that happen. This has to be done at a policy level.
Bigger level, right.
And so it would, because providers just don't have the resources to do this themselves. So I just mentioned two quick other policy recommendations. We need to collect, in addition to race, ethnicity, and language data, we need to get serious about collecting SDOH, social determinant of health data. I know some people are collecting it here and there, but it's not being done in any kind of consistent way. And we know that these upstream factors determine a patient's health much more than what happens in the clinic. And so to the point we were talking about just now, the provider is kind of like, bailing out a boat with 20 holes in it, because this patient comes to the provider with all of these social determinant of health issues that are much more determinative of their health than what that provider can do when he or she sees the patient. We've got to do a better job of investing upstream if we're going to really get to where we want to get to. And so from a policy perspective, good news, the Medicare Advantage program is a model. They have created this program called supplemental benefits, which allows some of the premium dollar for a Medicare Advantage member to be spent on upstream issues. That's a good thing. We should celebrate something good happens, but that should also be the case across the whole Medicaid program, because surely social determinants of health affect low income, which is the Medicaid program, even more than MA, but yet we don't have that flexibility in the Medicaid program yet. So that's a policy issue. We need to make that change. And one quick one I'd add is, if we're going to have more virtual care, and if we think that video particularly is going to be a big part of that in the future, we should include, in the plan, internet access. Why not? Well, a person should be included in their plan, internet access, so that they can access, and so the income is no longer this sort of gating issue for being able to use virtual care, particularly the video visit. Yeah, and I've got other policy recommendations, but you see my point here, that we aren't going to get there asking providers to fix all these problems. They're part of the solution, but we need policy change. And now is the moment that we should go for it, because of what we talked about earlier. This is this moment where there's an openness for real meaningful change, and we should go for it. We shouldn't be talking about little things. We should be talking about systemic kind of policy change that can really improve healthcare.
I couldn't agree more. Every panel I'm on, I always say, I'm like, there are no bad answers right now. There are only the questions that we haven't asked, but anything's game right now. Just toss it out there, and get it out there, and let's act on it. This is the time, to make change. And to your point, some of this, when I'm on panels and whatnot, I talk about this, kind of, you said, like sharing the load amongst all the stakeholders, like the payers. The payers should definitely fess up and take a cost share of that internet access. Health systems, if you're a health system and you're requiring a patient to be on a patient portal, okay, and get their test results and everything on a patient portal, you're again making that inherent assumption that they can access the internet. Right. And that's a bad, flawed assumption. So again, if you're a health system requiring that, again, what part of cost sharing are you doing to help that patient out? So absolutely, all these stakeholder groups are in it together. It shouldn't just be on the providers. We all have a stake in this. Okay, so next question. I think we're gonna go a few more minutes. We're gonna go till about 10 till with a couple more, and then we'll go out to our chat. So Abner, what steps can be implemented to actually engage with patients? How can you break the barriers and make the patients feel actively involved in their virtual care treatment?
I know I can certainly talk about it from the perspective of what we have learned at ConsejoSano in our engagement. First, it is that one size fits all is just not going to work anymore in healthcare. The way healthcare works today, the way we engage the patient, and this is true across all of healthcare, is kind of the old, I call it the 1.0 model of patient engagement. And it's about language and taking the same generic message, usually written by an English speaker for an English speaker, and then we translate it into 13 threshold languages, because that's required by the state or the government. But it's the same message. And so when you do that, when you treat everyone the same, what you're really saying is that patient, their life journey, their trust for the health system, their ability to engage in healthcare, their willingness to engage, how the social determinants of health uniquely affect them, what kind of, sort of history that they have in terms of myths they believe about the healthcare system, things they believe that just aren't true about healthcare and about health, also things that are true. You take everything that makes them who they are, and we're saying in healthcare today, that's not important. Don't want to talk about it. Don't tell us we're going to treat everybody the same. We might translate this message or this engagement effort. And usually we don't translate it well, but we might translate it, but that's it. It's a take it or leave it, one size fits all. That old approach is just not going to work anymore. And so what we're suggesting at ConsejoSano is that we've learned is if you can find a way to treat that patient in a more customized way, more personalized way. And what we do is we use a lot of data, public data and claims data and insights that we gain from that, as well as a team we've built that's very diverse and comes from the communities we're trying to serve. We built a technology platform that allows us to ingest all of that data. So what it really means is we are able to micro segment the larger population into much smaller groups, and then design the content for the smaller group. And that approach, and all it is treating the person like who they are matters. we're using information about them to engage them in a way that they, so that you, Stacey, and I have a whole different life journey. We're completely different. But if we were in the same health plan, other than a few sort of women's health issues or men's health issues, we would be treated exactly the same if we were in the same health plan. That's the way it works today. They might know you're what they would know you're a woman, I'm a man, but that's it. That's otherwise it's the exact same.
That's the only piece they're capturing, male, female.
Right, but we are completely different. And healthcare today treats us like it's one size fits all. And so to answer to your question, it's not an easy answer. But it is the answer. It is that healthcare has to become more like the rest of American culture, not just American culture, the rest of our culture. If you and I I'll use Netflix as an example. If we could be living in the same house and Netflix would have a different preference list for you than for me. They would figure out what you like and what I like. They recommend different things to you and me. If you buy a pair of shoes on Amazon and I buy a pair of shoes on Amazon, all of a sudden, they're going to start making recommendations to me about new things to buy versus you. Well, banking works this way. The rest of our culture treats people, because they're using data to do it, treats people in a more personalized, customized way that builds trust. And healthcare, which I think is the most important, much more important than Netflix, we're treating people like they're all the same. And so, yeah. It's hard. We have got to accept that the healthcare consumer is used to Amazon and Netflix and their bank, and being treated like who they are matters, and being treated like they're a consumer and their preferences matter, their choices matter. And if healthcare doesn't start to do that, people are going to choose different healthcare solutions that do a better job of that. So what I say to healthcare folks all the time is your customers are going to walk. They're going to vote with their feet if you don't start to treat them in a more customized, personalized way. Not easy all the time, but that's the answer to the question. How do we build trust with people? We treat them like who they are matters.
I mean, that's when you see some of these health systems. I'm doing a panel for Reuters, and the CEO of Highmark Health, who's actually here in Pittsburgh, he actually has a retail consumer background, that he's coming into healthcare. He's not a career healthcare guy. He has that. And to your point, I think that is so important right now to sort of, replicate some of these successful best practices that, like you said, that entertainment and banking and retail are using.
Everybody.
Everybody except healthcare, right? Except healthcare, which is, like you said, the most important.
It's most important.
Yeah.
But we're stuck in the 70s. We still treat everybody basically the same, and kind of, so I love the fact that some of these more, consumer friendly leaders are coming into healthcare and trying to bring some of that to healthcare, but it's not happening fast enough. And a lot of the disruption that's going to happen in healthcare is going to be by new entrants who come in and understand we got to treat people better. The old days of just saying to the patient, take it. This is you have one choice, yeah. And you're going to love it, and that's it. Those days have come to an end, and people want to be treated better.
Yeah, like you said, vote with your feet. Vote with your feet. Yeah. So I'm going to go out to the chat now, and everybody who knows me as a host knows that I'm not a good multitasker at all. So Abner and I we're gonna join each other here, and we're gonna look at the chat here. I'm going right up to the top to tell you right now that I'm gonna go from the top, and we're going to both view this chat, and as we see some questions, we're gonna tackle them. So bear with me. And the other thing I love about the chat, about our audience, is the community that we're building here through OSP, and you're talking to each other and you're engaging with each other. That's what we want to see. We want to see that free flow of ideas. So thank you for engaging with each other. Here's a question, Abner, from our friend Charisse. It's a good one. One of the areas where lack of equity is apparent is in the clinical trial genre. Boy, is that true. Marginalized patients rarely receive discussion about the availability of trials, and this needs to change. Abner, how do you think we do this?
That's a big one. Yeah. I think I think one of the key strategies is for, and it's usually, drug manufacturers who are leading a lot of these trials, not only those, in some cases, the devices, but I think the key here is how do you build trust so that you can get people to get them information about the trial and get them to sign up. And one of the things that we've seen really be effective is for the manufacturers, whether it's a drug or a device, to have a better relationship with doctors who are diverse. If you look at a lot of times, too often, the manufacturer will go to doctors or providers who they kind of have an existing relationship, part of their network or something. I think a key to getting more diverse patients is getting more diverse, providers, building a relationship with that provider, because you're never going to, I don't think that the manufacturer is ever going to be in a better position than the provider to talk to the patient about a new opportunity. And so one of the key things is to build out that network of diverse providers. And so that's number one. And as part of that, we need more diverse providers, right? We still aren't seeing enough, Hispanics and African Americans and other folks going to medical school. And so there's a need to support that effort. So there is a pipeline issue here. So it's not, I don't think it's that you do just one thing. That we need to build a better relationship with providers who are practicing, because that's the best way to reach their patients. But we also need to create more diverse providers and do more, help supporting getting folks through medical school and targeting diverse communities for that. And then I think there's also this issue of how you communicate with both people you are trying to engage in a trial and even people who are in the trial. More often than not, all of that communication is all English. It's almost never culturally and linguistically appropriate for diverse communities. So if you want to get a more diverse population in the trial, but everything you've produced and all of your outreach is English focused, it's not the best approach. And so I think those three things really, you got to focus on the providers who are diverse now, help to build the pipeline, help to build relationships with some of those providers, so you have a relationship with, if you're a manufacturer, you've started to get to know these doctors even before they start practicing, because you're supporting efforts to increase the number of diverse doctors who get through medical school. And then I think making all of the communication, both with existing folks in the trial and potential trial members, we got to get beyond this one-size-fits-all English-only approach, because that's not the way you're going to recruit a really much more diverse trial population.
I couldn't agree more. I see people, sharing some links about, I think that a lot of this too, what we're talking about, it goes back to how we're training physicians and what we're saying in med schools, and what the training and the education, and especially with what happened with open notes now, and data and notes being transparent to patients. That's a whole nother webinar about how to communicate with patients and what those notes say, and are they able to be read and understood by patients, and beefing up patient navigation. That's a whole nother webinar. But I see this is sort of related from a friend of mine. How can life science organizations help to close the health equity gaps? I think you talked a little bit about this, about a front-facing, our human resources being diverse and reflecting the populations that we serve. And there's just so much discussion here. This is a little overwhelming. People are sharing so many good ideas. A comment about, yes, just male, female being sort of binary tags, making sure that the data that we're collecting is inclusive, certainly, right. He, she, they, certainly.
And interoperability is a big issue here, because, persons shouldn't have to, when I go to an ATM machine, I can put in my card anywhere in America, anywhere in the world, and get cash out. And yet I can't go to two providers on the same street. Their systems don't talk to each other. I mean, they can literally be across the street from each other. And so this is what I mean by healthcare is stuck in a bygone era. And so again, two policy recommendations. One is we got to get serious about interoperability. It's just ridiculous that I can do that with my bank card, and yet my data is siloed in EHRs, and they don't communicate with each other. That my health information is mine. It's not the providers, and so we need to get serious about interoperability. I'm not saying that there aren't issues that we got to sort out, but let's sort them out. It's 2021 and we need to resolve this interoperability problem. You shouldn't have to go in and tell everything to either if you keep records yourself, or have to go in and repeat everything all over again. It's just, it doesn't, that doesn't make sense. And then I know this might be a little controversial, but we're not going to solve the interoperability problem and some of the other issues around making healthcare more consumer friendly if we don't revisit HIPAA. The policy, the privacy, HIPAA, it was supposed to be about patient privacy, and it has become a law that now is all about protecting providers and health plans and everybody else. It's no longer about the patient. HIPAA needs to be revisited in light of the technological revolution that we have undergone since HIPAA was put into place. And I know some people are going to, get all afraid that, that we're going to not say privacy is important. Privacy is important, but we live in a different era now than we did when HIPAA was written. And certainly if you look at the next, 30 years, we have got to accept that a law written, 10, 20 years ago is not going to work, 20 years from now. We have got to update these laws and revisit them and make them work for today.
Right. No, I couldn't agree with that more. Patients who contact me to get them help, to get them second opinions, like I always say on panels, is when your life is on the line and you're fighting for your life, you don't care about privacy. You don't care who's seeing your records or who's trading them or where they're going. I mean, patients have literally sent me reams and reams of paper, not even knowing me, other than, my presence on social media, what I do, but sending me their entire health record to say, save my life. They don't care about privacy.
We've got to do better. We've got to, it's an outdated law that we need to change. It needs to be revisited. And none of us is saying privacy doesn't have a role. It does. But technology, we have completely changed the way we deliver healthcare now, and what consumers want and what consumers are comfortable with. And the laws need to reflect that. And to date, they don't. It's more of it's no longer about patient, protection. It really is about protecting, other people, providers and health systems and health plans from getting sued. No one talks about what the patient wants and what's in the patient's best interest. And I think it needs to change to reflect that.
Patient number one here in agreement. So Abner, we're coming down to the final couple minutes, and audience, thank you so much for all of your comments. We're going to roll up the chat. Anything that we haven't gotten back to you on, please reach out to us at OSP and we will get you an answer. We'll get in touch with Abner if we can, although he, like I said, I'm just glad I got to him before health, because he's the guy I could hear from here. But Abner, just in this last minute, is there anything that you want to add, anything that you want to say to our audience?
Yeah, I just close by saying, this is a hopeful moment that because of, what happened over the last 18 months, we are just in a different place than we have ever been. And we've got more people committed to health equity. We've got more companies committed, not only in healthcare, but across the economy. We've got government committed at the state level and the federal level. We have better tools now. We have better data now. We have better technology now. This is a moment for us to get serious and make the big changes that we need to create a healthcare system that works for everybody, regardless of what they look like, what they talk like, where they come from, or how much money they make. Moments like this don't happen often, but it's happened, and we're in it, and we've got to make sure we don't squander it. So let's just work together to improve our healthcare system.
I couldn't agree more. Abner, Thank you so much for joining us today. Audience, thank you so much. Please follow Abner on Twitter, Abner Mason, Stacy Hurt. We're out there. Please follow OSP and subscribe to updates on our upcoming webinars. We so appreciate your time today and everything that we're all doing together to make positive change in healthcare. Have a great day, everybody. Abner, thank you again. And
Thanks so
let's
much.
talk. All right. Thank you. Bye, everyone.